Hello and welcome to Healthcare Voices, where we bring you authentic voices behind healthcare innovation and impact. I'm your host, Katherine Cummings, former clinician turned technology advocate. And today I have the privilege of speaking with Michelle Whaley, an advanced practice nurse and former market director of stroke and neurosciences at Skyridge Medical Center and HCA Health One Denver. Michelle is a passionate advocate for improving care for stroke patients and has been a national and international speaker on the topic since 2009. I'm thrilled to have her on the podcast today to share her expertise on the future of stroke care. Welcome to the podcast, Michelle.
Hey, thanks for inviting me. Happy to speak with you.
How did you start your career in nursing? And I know that you started your career in critical care. What drew you to really specializing in neurovascular care or stroke care?
Well, I started off in healthcare working as a unit secretary and a critical care technician. And it was the trauma ICU nurses that encouraged me to go to nursing school and kind of put me through school. And we had a really large neuro population in that ICU. So it was always an interest of mine. And when I started graduate school, I was connected with a nurse practitioner group at Swedish, and they were focused in stroke. And I did about 500 hours of clinical time altogether in different specialties, but I really enjoyed my time with the stroke population. And so that's how I got into it. I had a great mentors, and I could see how it was done really well. And I wanted to emulate that and make that my career.
Coordination of stroke care requires a lot of moving parts. Can you provide an overview of what your role as an advanced practice nurse specializing in stroke care looks like?
Yeah, sure. With acute stroke, especially in the beginning, it all started with the release of a medication known as Alteplase, which the name brand was Activase, and it came on the market in the late 1990s. And the medication itself didn't really take off in being treated with for patients. What the advent of stroke centers, that's really what brought along process change. So when a patient comes to the hospital, typically things happen in a linear fashion. Like the patient arrives, they go to triage, they get a room, then they get a nurse sees the patient, then the doctor sees the patient, and treatment decisions are made. With stroke care, everything is very time sensitive. So it all has to be done simultaneously in the first, 60 minutes of acute treatment. With drugs like Alteplase, and now there's an old drug that's new again, Tenecteplase, that's being used in acute treatment for stroke. And then there's surgical procedures now that can be done. It's so time sensitive that when patients arrive, we need to be doing things simultaneously. So what a really great stroke alert looks like, or code stroke, is when a patient or a person experiences stroke symptoms and their family or they themselves recognize it and call 911. Then EMS providers on the scene do an assessment, recognize it's stroke or stroke-like symptoms. They call the hospital ahead of time. They choose a good destination hospital to bring the patient to, and then they let the team know we're bringing a stroke patient in. From there, the hospital then dispatches a stroke alert page. The team gets down to the ER, whether it's in person or via telehealth, or whether it's nursing, advanced practice nursing. So like for me as an APP, I would go to the emergency room and I would be present when the patient arrived. That way I could hear the story the first time from EMS. And then we would quickly assess the patient while someone was ordering the CAT scan, while another team member was meeting with family, while another team member was determining eligibility for acute treatment. From there, we would clear the CAT scan table, take the patient there quickly. Our goal would be to only be at this area we call the launch pad, which is a spot between the EMS ambulance bay and CAT scans, kind of halfway. And we would stop and spend no more than 4 minutes assessing the patient and getting them registered, because we wanted to get to CAT scan as quickly as possible. Then when we're on the table, we want that CT to be done within, 5 minutes of getting on the table. So the patient then is on the CAT scan table, and we're focusing on getting the images done quickly so that way they're read fast. The neurologist reads them on the console. The neuroradiologist gets a phone call and they look at it and are communicating directly with the team. We have a pharmacist standing in the room ready to mix the drug. We have a nurse ready standing by to give the drug so that we can give the medication as quickly as possible. So I think if we eliminate wasted time, you could do it in under 30 minutes every time. For a long time, it was considered crazy to think you could treat somebody in under 60 minutes. When I was at Swedish, we were able, our median time door to needle is what we called it, for Activase and then now Tenectaplace times were consistently under 20 minutes. Again, you're eliminating all the wasted time in treating someone. And then if they're a thrombectomy candidate, which is that surgery to remove a blood clot, we employ the same kind of great process to eliminate wasted time and get the patient to treatment quickly. So as an APP, I might be the assessment person. I might be the timekeeper. I might drag the patient to CAT scan or ensure that the interventional table is free so that the provider can come in and perform the thrombectomy surgery. So as an APP, I wore a lot of different hats when I was involved in stroke alert process.
Well, I know they say time is brain, right? In any kind of stroke situation.
Yes,
So getting them from door to needle is extremely important, right?
absolutely. It's everything.
You were saying that from thrombectomies are being employed a lot these days, and that's kind of a newer technology. How has other technologies transformed the way that you manage and treat stroke patients in the acute setting, whether it be a surgical intervention or other kinds of technology?
For stroke in the last 5 years, I think the biggest improvement was the advent of artificial intelligence software and applications to determine large vessel occlusion. So there were two companies, there are more companies now, but the two main ones were Rapid AI and Viz AI. Those are both app-based programs that are embedded into CT technology. So when the images come off the console, they get uploaded into the cloud and they take two different paths. One path goes to the radiologist and the other path goes to Viz, let's say. That was the technology I'm most familiar with. And then the computer would look at each slice of the CAT scan, and if it determined there was a large artery blocked, it alerts like an Amber Alert. And what it does is you've got all these providers logged in to the application itself, neurologist, neuroradiologist, different interventionalists, neurosurgeons, stroke APPs like myself. And it like sends out like this blast to everyone in the city. When at the facility I was most recently at, Skyridge, that's a smaller hospital. All the teams are all off site. And when that Amber Alert, so to speak, would go off, everyone stops and looks at their phone and says, wow, there's a patient with a large vessel occlusion at Skyridge. And it like shaved off time. So to me, like that was the most important thing in the last 5 years that has come along is the artificial intelligence software that helps us identify the large vessel occlusion. There's another really cool device I heard about this year that is attached to the catheter. So if you think about thrombectomy in terms of like a cardiac catheterization, most people know what that is, where they use the artery either in the groin or the wrist and they kind of feed it up. Normally, if it's a heart cath, they go to the heart. Well, in the brain, they go up through the carotid and then up over to the vessel that's blocked. This new catheter has artificial intelligence software that part of the catheter and the device it's attached to helps regulate the amount of pressure that is used to pull a clot out. And it's the overwhelming kind of evidence so far is that it's going to help prevent vessel damage because it's going to auto-regulate how much pressure or pull is being kind of put against a vessel wall, which
That's
that can cause
really
damage and
impressive.
cause other
Wow.
problems.
Yeah.
That's pretty cool. That's new and up and coming. I don't think it's been released yet, but I heard about that earlier this year at a conference.
We hear AI being utilized a lot of different areas in medicine. And I know before this podcast, we kind of quickly had a discussion about the use of AI and the use of augmented reality or AR being used for stroke recovery. I'd love for you to talk about that a little bit in addition to the AI.
Yeah, this new technology, it's called the Real System. There's probably others out there, but this is a virtual reality headset that it's really the proprietary software that's so cool. I got a chance to test it out in 2020, right before COVID. And we put, like you put the virtual reality goggles on and it transforms you to, or transports you to this place called Happy Valley. If you're a stroke patient, a lot of things are in your head and it's the brain connecting to the body to lift the arm up. And if you're paralyzed, right, from a stroke, but you're trying to use therapy to rewire the brain so that you can lift your arm again, when you're in Happy Valley, well, that's a place where everything works, right? And it was kind of a cartoon land. And the first thing that they did for me was I got to see this penguin that was throwing fish at me, and I had to dodge the fish, which is good truncal stabilization, right? And then the next thing that they had me do was raise the sun, and you had to use your hands to raise the sun up. And so it's more like, and in that Happy Valley, you can raise the sun. And whether your arm is working a lot or a little, but your brain starts to think about it in that way. There were a lot of different programs that the Real System has that I think are kind of the future of how we start to recover and how we start to rewire the brain. It's still in clinical trial in certain places to see whether it's truly going to improve outcomes. But if it makes somebody feel better and have less post-stroke depression, to me, that's a real benefit. So, more to come on that. A lot of these things are all still in trial or not necessarily evidence-based yet. But, as you think about, like, I really believe that made me feel better. And now I have better use of my arm. Whether there's true evidence out there or not, it made that patient feel better.
There's a lot to be said about that kind of mental component, especially if you're losing the ability to move in a way that is so normal to us. My father actually had a stroke many years ago. And I remember the time that he spent in the hospital recovering was kind of just the tip of the iceberg, or just the beginning to a very long
Oh, yeah.
recovery. And, with access to all of the new technology that we have versus, now versus 10 years ago, what are some of the other types of things that you're seeing? How are we tracking and measuring outcomes? How are we seeing new types of technology being utilized for stroke recovery once patients are really transitioned out of that acute setting?
See most of the new technology being focused on prevention of damage. That's where I see most of the new technology. I am seeing more and more rehabilitation centers step up and focus a lot of their care and abilities on stroke patients and looking towards advanced certifications in stroke, which means that they're spending time really focusing on those patients and their outcomes and providing the right resources for families and patients after discharge. As far as tracking and looking at how well patients recover, like what's the data part of it, there is an assessment called the Modified Rankin Score. And the Modified Rankin Score has been around in stroke literature for some time. And it's a requirement of stroke centers to assess patients kind of before discharge and at 90 days. And the initial thought is that the 90-day time frame is when you're going to see the biggest improvement. But we also know that the brain is plastic, which means the brain can continue to recover long after 90 days. And that's why we focus like recovery continuing well past that 90-day mark. But the Modified Rankin Score itself is a 6-point score, 0 being completely normal, 6 being you've died, right? So as we look at somebody at discharge and at 90 days, when I make a phone call to a patient and I'm asking how they're doing, I usually start the conversation with, are you back to normal? And usually people will start saying, well, no, my hand still is a little weak, but I'm back to work and I've been driving for the last month. That tells me they're pretty good. They're probably a Modified Rankin Score of 1, mild symptoms. Then Modified Rankin Score of 2 is probably somebody who has some symptoms and some level of disability, although it's fairly mild. They can be left alone. They may need help managing money, or they may need help with driving. Maybe they're not driving yet, but their activities of daily living, like toileting, dressing, bathing, all of that, they're able to do themselves or with minimal help. A modified ranking score of 3 is probably somebody still in rehabilitation, but they can walk independently even if it's with a walker. The next would be a modified ranking score of 4. They're probably in rehab, but they could also be in skilled rehab where they need more supervision. They might need 24/7 care, but they can do some things. They can participate in rehab. Modified ranking score of 5 is somebody who's bedbound. They need 24/7 care. They're probably not at home. Their family probably cannot manage them. And then, of course, 6 is that they've died. What we think about in acute stroke care, a good outcome is 0 to 2. Right? We've got you back home. You're independent or a little bit disabled, but not a lot disabled. And you've essentially got your life back. A 3, acute rehab, well, you're on your way to that. Hopefully, acute rehab helps you get to that point to where you've got some level of independence. The 4s and the 5s are a lot harder because those are people who had probably really big strokes, and recovery is going to be tougher. I love when we have a miracle in a hospital, like patient comes to the hospital right away, they get alteplase or tenecteplase rapidly and safely. They go for thrombectomy, blood flow is restored, damage is minimal. That's a miracle, right? We reversed a stroke. But unfortunately, that doesn't happen in all of our patients, right? It might be half of our patients, and the other half, or maybe a quarter of that half, didn't get to the hospital in time. Maybe they didn't even come in for a few days. Maybe they were found down and nobody even knows when they were last seen normal. Those are the people that need a lot of care and assistance. And so, as we track our outcomes, we don't want to do a lot of surgeries and procedures to lead to a lot of patients in nursing homes. I guess unless they find that to be a life worth living. There's a fine balance. What I consider a life worth living may be different than what somebody else, and then different than the guy down the street. So, you know, it's asking the families what they want and trying to make really good decisions, keeping in mind that the decisions that you make, you really won't know for sure for about 90 days on whether you made a difference or not.
For this podcast, you told me that one of the biggest challenges in post-stroke care is that it is so hard to get a follow-up appointment post-discharge. Can you tell us a little bit about the impact that has on long-term recovery for stroke patients?
Yeah, we saw during COVID, there were also some CMS changes. The COVID kind of impacted outpatient clinics, and then a CMS rule change. I don't fully understand what it was about the rule change, but it did change reimbursement and how medical practices were able to, like recoup costs or get reimbursed for certain things that they did. And a lot of neurology practices have struggled to stay open in the last few years. And now we find ourselves, at least in the Denver metro area, we have a shortage of outpatient neurologists, and patients would get discharged with recommendations to follow up within 2 weeks, but yet the local community neurologist couldn't see patients for 4 to 6 months. And in rural areas, it was even worse, like 6 to 8 months. So this was earlier this year, I started getting a lot of phone calls from patients saying, hey, I can't get in. What am I going to do? What do I need to do next? And I would walk them through those steps. As we think about like how patients get follow-up, what do they need? What do they need that neurologist to do? And it's usually they need the neurologist to, one, explain what happened to them, help prognosticate what's going to happen next, and make sure that they're taking the right medications. What I started seeing as the months went on this year and in the year prior, we were starting to see more patients come back in with a second or a third stroke. And, it was maybe because they didn't get their medications refilled, or they didn't quite understand why they needed to take their aspirin and Plavix, or maybe they didn't understand that they needed their blood thinner plus an aspirin. So we were starting to see patients come back in with additional strokes, and that has been worrisome to me. Personally, as somebody who's spent the last 15 years of my career focused on reversing stroke, and then to only find that those efforts we're finding patients come back with new stroke like that. To me, that's unacceptable.
Anything. I understand that you're opening a follow-up stroke service, a telehealth
Yeah.
service, and I think all of our listeners would love to hear more. I especially would love to hear a little bit more. Can you share that with us?
Sure. Well, I got the idea from a colleague of mine. She's a nurse practitioner who opened her own concierge NP practice. And I met her like at a Christmas party last December. And she was telling me how, yeah, I don't have a brick and mortar location. I am seeing patients in their home, or I'll come to their executive office, or I'll see them on telehealth. And that's how I'm going to see my patients. And that kind of sparked the idea in me that, wait a minute, I don't need to have a brick and mortar location. I can go to someone's home and see them. And if you think about somebody with a stroke, are they very mobile? Not always, right? Or it may be difficult for their family member to get them in the car to get to a doctor's appointment. So the idea of doing like maybe a home visit or a telehealth visit was really desirable. I think could be desirable in the community. And as a provider, that's something that I can take care of. Like I can get started in July and start seeing patients. Now we're looking at the direct payment model, which will, I think, make our availability to patients greater. When you are in a traditional office, you're kind of required to see patients like every 7 to 15 minutes. You don't have a whole lot of time to spend with people. And in a concierge or a direct payment model like what we're looking at, the patient would make the appointment, would pay for our services, and then we would provide that service. And because we're not on a deadline or we don't have the pressure to see as many patients as possible in a day, I can spend an hour with them or whatever the patient needs, right? So if I go to their house and their family has a lot of questions, then I'm going to sit with them and answer their questions. And I'm going to make sure that their prescriptions are filled. Maybe they needed their prescriptions sent to their mail-in pharmacy. I'll take care of that for them. I'll make sure that they have that kind of transitional time, that 90 days where their meds are filled, that they understand what happened to them, that we've optimized their risk factors, and that we've communicated with their primary care provider with a good handoff. And then hopefully prevent that additional stroke from happening again. I mean, sometimes you can't, I mean, it's biology. Sometimes you can't stop it. But I want to set up our patients to have the very best opportunity to avoid another stroke, to get their lives back, to get the referrals made. A lot of patients need to get heart monitoring. And so, maybe I'm going to make that phone call to cardiology for them and get their appointment scheduled. Things like that, that I think the community will really appreciate.
That's amazing. I think the quality of care is really important, especially with patients getting out of that acute space, and the follow-up care that you're going to provide is really exciting, especially coming from someone who has a parent who had a stroke, and all of the appointments that need to be made
Oh
alone
my
are
God.
really overwhelming for people. I'd like to know a little bit more about how you plan to care for stroke patients, regardless of socioeconomic status, geographic location. How are we addressing those types of things, regardless of whether a patient has maybe the ability to pay or things like that?
Well, first off, telehealth or telemedicine does open up the ability for anyone in the state of Colorado to request our services. So that's bringing the provider to a rural or frontier area is huge. And we saw that with the advent of just neurologists being, like telehealth cameras in emergency rooms. Now, as far as economic status, that's going to be more challenging for us because we're going to require payment up front. Now, as we move forward in the months that follow, if we prove the concept that patients will want to see us in this way, will value our service enough to pay for it, for us to see them, we've talked about how we could provide patients with scholarship, to get our services if we're not accepting insurance and or Medicaid or Medicare, right? We're not bound by those laws either. So that allows us to make decisions on what we accept in payment. That we'll have to see how that bears out and what the market brings there. Ultimately, in the future, we may actually accept insurance. It's hard to say what the market will bring because personally, I want to make sure that everyone gets seen. And That's important to me. So we'll have to see what happens with the business in the months to follow.
It's really exciting what you're doing. I have a couple of other questions regarding how do you stay up to date on the latest stroke advancements? How are you implementing best practices? I'd love to hear a little bit more about those things. I know that you are a very comfortable speaker. You've spoken internationally and nationally, and you've presented many, many posters. So I know you're very ingrained in the newest technologies, the newest education. How do you stay up to date?
I think membership in organizations is important, and reading journals. So the first thing I do is every year I go to a conference. So I like the International Stroke Conference. I also had the opportunity to go to the European Stroke Conference last year, and I really loved it. It's so interesting. These international conferences are typically English speaking conferences, so it isn't even really a challenge to go. But it is a little bit different, and how like the Europeans may look at stroke versus how the traditional like American Stroke Association looks at stroke care and what their guidelines are. It was really eye-opening to do kind of both in one year. I've been on the board of the Association of Neurovascular Clinicians. That's an APP led organization, or advanced practice nurse led organization. And staying current there, reading those journals. So the Journal of Stroke, the Stroke Clinician, other journals, being really well read. And then from those organizations come clinical practice guidelines. Clinical practice guidelines really are the guidelines that guide the practice in the hospital and out of the hospital. So, for example, in this new venture of mine, Next Step Stroke Clinicians, we're going to use clinical practice guidelines in our own practice. There's a guideline from the American Stroke Association on the prevention or secondary prevention of TIA and stroke in patients who've already had those events. And it kind of like line by line tells you these are the recommendations by a group of experts in practice, using the latest, greatest information. This is how we should practice. And I love having clinical practice guidelines because it's not that it takes the guesswork out. Every patient's individual. You have to individualize care for everything. But it gives you that foundation and that guideline to know what the right standards are. And then you go from there. So that's how I stay current.
And I like to end the podcast with one final question. What's one thing that you wish people knew about practicing medicine, or maybe one bit of knowledge that you'd like to impart on our listeners?
I think I'll go with the signs and symptoms of stroke and the need to get to emergency services. So there are a couple of different acronyms that are out there. FAST is the one that's most well known. I like BFAST because FAST tends to focus on the signs of stroke that are happening here. The back part of the brain, the brainstem, gets missed if you just only think about face weakness, arm weakness, or speech difficulties. So B in BFAST stands for balance and difficulty walking. So if you find like suddenly you've got sudden onset dizziness and you can't even walk, you're so dizzy you need to hold on to the wall. And maybe it's new dizziness for you. That is a sign of stroke. E stands for eyes. It can be eye movement side to side. It can be vision loss. Usually it's vision loss in half of the vision or a portion of the vision on both eyes. You really only notice this side. People typically don't miss vision loss here. Let's see, F stands for face, so face weakness. So one side of the face droops. You can see I've got good creases here. You would notice a decrease in kind of the nasolabial fold here, or maybe see, other, wrinkles or the way the face changes. Face weakness isn't present in everyone, so don't hang your hat on that. You can have stroke symptoms that are very isolated, like in the front part here, might be isolated in the leg. So it's sudden onset, lack of function. So if we move on from face, arm weakness. Weakness is typically one side, one arm drifts down. You could also think about it in terms of the leg, one-sided leg weakness. If you move then to speech, S, difficulty speaking, difficulty understanding. Those are kind of the hallmark of somebody who's who's having an event, especially on the left side of the brain. So thinking about signs of stroke, if somebody's having a left brain stroke, they may present with right-sided paralysis, speech difficulties, and facial droop and vision loss. Those are kind of the key things. If it's a right-sided brain, they may speak just fine, or they may have slurred speech, but they may neglect part of their world, right? So if it's the right side, that's the left side of the body, they neglect the left side of their world. Patients who are having strokes in the back part of the brain, that's going to be balance. That might be vision loss. It might be double vision. Sudden onset double vision is a stroke syndrome, not blurred vision, but double vision. And again, that sometimes face weakness can show up, and all of the above. So T is the last part of Be Fast. Time to call 911. Don't try to drive yourself in. Don't talk your wife into driving you in, or telling your husband, I'm fine, don't call 911. You really need to call 911. EMS is going to show up. They're going to help you. If you're having a big stroke, you don't want to be walking out to your car. You want to be lying on a gurney. You want somebody to be managing fluids and making sure that the team is ready for you, so that as soon as you get to the hospital, you're not standing at the triage desk explaining your story. You want EMS to tell your story, and you want the process to move fast. When people come into the ER to triage, that's going to slow things down by 30 minutes. And I don't think the average public realizes that. Like, EMS speeds the process. So when it comes to stroke, be fast, activate EMS, and, really don't sit on it. Don't think, I'm going to take a nap, I'm going to feel better. Act on it fast, and, give yourself the best opportunity to reverse a stroke in progress before there's damage.
Perfect. Thank you so much for sharing that. And thank you for sharing your expertise and insights into some of the exciting advancements that are happening in stroke care and on your new venture. We're all
Thank you.
very excited about that. I really appreciate you sharing your time with us, and I'm excited to hear more from you in the future, and looking forward to seeing the launch of your new telehealth service as well. So thank
Thank
you.
you.
Thank you to all of our listeners for joining us on the podcast today. We appreciate your support. To hear from more healthcare voices like Michelle Whaley, hit the subscribe button and send this podcast to your friends and family. I'm your host, Catherine Cummings, and you just listened to Healthcare Voices.